Hi, everyone. I'm Dr. Laura Leahy. I'm a psychiatric and addictions advanced practice nurse in private practice in Southern New Jersey outside of Philadelphia. I'm thrilled to be with you today, albeit virtually, at the Yankton Mental Wellness Conference 2021. Today, I'm going to be presenting on the addicted brain, opiates and substance use disorders, and I have two other presentations later in the program. So I have a practice, like I said, a private practice. I've been a nurse for over 30 years, an advanced practice nurse for 30 years, and I've always practiced in the mental health and substance use disorders arena in every possible setting. So I'm hoping I'll give you a good idea of what goes on with the addicted brain and how opioids and other substances create problems for us and how we can potentially move forward and help our patients achieve the wellness that we all so strive for. Here's my faculty contact information. Please feel free. I know this is a virtual conference, so feel free to email me if you have any questions, if you'd like larger prints of the slides. My handout should be part of your packet, so just let me know if you have any other questions that I might be able to answer post-conference. My disclosures for today on the addicted brain. I'm going to be potentially discussing off-label or investigational use of medications, in particular the anticonvulsants, antihypertensives, antidepressants as potential treatment options, and medication-assisted withdrawal options for substance use disorders. And I do have a couple financial relationships to disclose, albeit they do not impact my presentation here today. I am a consultant for Alkermes, which is the producer of Vivitrol. I'm also on their Speakers Bureau and also on the Speakers Bureau of Rexulti, which is produced by Otsuka Pharmaceuticals. I've also written a book, The Manual of Clinical Psychopharmacology for Nurses, published by the American Psychiatric Publishing Association. It's from 2013, so albeit, there are a number of outdated, well, medications aren't never outdated, none were taken off the market, but there are a lot of new medications since 2013. So some of the material is a little dated there. Today, we're going to go through the anatomy and physiology of the addictive brain, what goes into the brain, what kind of genetic factors influence substance use disorders in our brain, and what kind of major neurochemicals influence our pharmacologic treatment of the addicted brain. We'll also talk about the medications that we can use to treat patients with substance use disorders. So addiction, you're going to hear me use a couple of terms interchangeably: addiction, substance use disorder. We are really trying to move the language of substance use disorder treatment in a different direction, away from addiction. However, most things that are published these days still use the term addiction. So if you hear me use substance use disorder, it's interchangeable. As ASAM, the American Society on Addiction Medicine, defines addiction, it's a fundamental neurological disorder of the brain's reward, motivation, memory, and other circuitry. Our national government and the drugabuse.gov organization describes it as a chronic relapsing brain disease characterized by compulsive drug seeking and use despite harmful consequences. So if we think about this in the context of treatment and in the context of medical disorders, we want to begin to look at substance use disorders as chronic relapsing diseases, just like asthma, just like diabetes, just like high blood pressure. And for those of us in the medical realm where we're prescribing medications, we need to rethink the way we do this, in that we don't want to be punitive with our patients. Rather, we want to help them in this journey of recovery and harm reduction. So addiction's not a moral weakness. We used to think it was. A patient should be able to resist. It's not a bad choice. This is something that's going on up here in the brain, and hopefully you'll all walk away with that understanding when we leave this presentation today. It's not a lack of willpower. It's a disease of the brain. Just like asthma is a disease of the lungs and pulmonary system, just as high blood pressure, a disease of the circulatory and cardiac system. We need to rethink the way we look at it. So, as we know, many of our patients in our country with substance use disorder choose alcohol as their drug of choice, followed by marijuana. I don't think that's a surprise. And now that we're seeing legalization, I'm not sure how many are considering it actually a use disorder at this point. And then coming behind that is prescription opioid abuse. This is nothing new in our country. We've had prescription opioid use and use disorders since the Revolutionary and Civil War times, where patients were prescribed morphine and other opioids to relieve the pain of the field amputations that they may have suffered or other traumatic events which caused physical injury. And they're using morphine primarily to help manage that pain. And patients became addicted. I think if we look back at Teddy Roosevelt's time, they actually quantified that and said that there were 10,000 individuals in our country who were at that point, 100 and some odd years ago, 150 probably plus odd years ago, that were actually addicted to prescription opioids. So this is nothing new, although we have it on a much larger scale today, and we've seen it over the past decade as having a prominent focus in our society. The other substances that we, typically think of, cocaine, tranquilizers, which would include our some of our other narcotics, heroin, hallucinogens, stimulants like the psychostimulants used to treat ADHD, the inhalants, and sedatives, which can be our prescription sleep aids, as well as prescription benzodiazepines, or Xanaxes, Valiums, and the likes, round out the substance use disorders by drug of choice. It's interesting to see how at the bottom of this screen, the sedatives and hypnotics are very, very low, yet we have a major focus in our country about the benzodiazepines and their addictive properties. So we're in the midst of an epidemic within the COVID pandemic. This is a slide from 2017, we still have more Americans dying every day from drug overdoses than from automobile accidents in our country. And the majority of those involve legal prescription drugs, not just the opioids, but other prescription drugs that may have contributed to a drug overdose. When we think about these drug overdoses in light of COVID, we know the documentation now coming out a year into the COVID pandemic shows that we have a 30+% increase in drug overdose deaths since the start of COVID. So this has been a real obstacle. We've also seen a huge rise in mental health needs in our country as well. Suicides have risen proportionately. So where we were getting a little bit of a handle on this opioid epidemic, we have now kind of in lieu of COVID seen this increase once again, which is very, very unfortunate. And our substance use disorders don't start as adults, most of our individuals. 7 out of 10 teens who were non-medical users used prescription opioids with other substances, meaning non-medical users, meaning they're not using it because they had an ACL repair, or they're not using it for a medical purpose. So these are misuse and abuse of these medications. If they're using prescription opioids, almost 60% are also using marijuana or cannabis along with it. Over 50% are also using alcohol along with it. 10+% are using either cocaine or the tranquilizers, and almost 10% are using the amphetamines. So polysubstance use is still alive and well in our country. Although this slide is from 2012, it's been replicated over and over. Older adults are also not immune to substance use disorders in our country, yet most will go unnoticed. It's a group that we don't tend to think of things when individuals come into the emergency room with change of mental status. We're going to do lab workups. We're going to look at urinary tract infections and all of those types of things. But often this population doesn't get the urine drug screen or even the serum toxicology screen. So substance use and abuse in this population often goes unnoticed. There are many of our older adult population that have polypharmacy because they have multiple issues. They may have COPD in addition to coronary artery disease, which also complicates matters if they're introducing substances, alcohol, opioids, or other drugs to their presentation. In terms of this population as well, heroin use disorder, surprisingly, is second only to alcohol in individuals 50 years of age and older. That was somewhat of a surprise to me when I was putting together some of these epidemiologic statistics for you. And we see that many patients who are on Medicare Part D, which is the prescription plan or the prescription part of our Medicare, we see that many individuals are prescribed more than 90 days worth of opioids. And we saw a huge increase in this prescribing of opioids in this population. It's estimated that about 5.7 million adults age 50 and over need treatment for substance use disorder. So given that I'm going to be 56, 50 and older doesn't seem like the older generation, but I guess I have to come to grips with that reality. Other things that lead this population to be at risk for substance use disorders is that social isolation, the depression, especially in our much older population, our elderly population, as they see their family members and friends begin to die. This also may lead them to feel more lonely, seek out other things to numb that pain. So it's a population that we really need to pay attention to. So where are people getting their medications? Where are they getting these prescription opioids in particular? Let's start with the prescriptions, then we'll talk about some of the other, illegal substances and the likes. Well, again, hopefully you're aware of this, but we used to think that many of these substances, especially the prescription substances which are abused, came from multiple prescribers, came from people who were going around doctor shopping, if you will, although I'm an APN, so I suppose I should be included in that doctor realm, and that they were seeking prescriptions from more than one practitioner. They were seeking prescriptions from more than one pharmacy. They might be paying cash for some, insurance for others, or they were getting it some other way. Well, what we know now is that far and away, only these individuals are getting their prescriptions from only one prescriber, using only one pharmacy. And more often than not, over 50%, well over 50%, are getting their medications from a friend or a family member or a relative. They're not stealing it, they're actually, being given it. So if somebody comes into your home and you might have had an old bottle of oxycodone sitting around on the shelf because you had a knee injury years ago, and they say, oh, wow, you know what? I have the same kind of symptoms you had back then. Do you have anything? I'm really, really hurting tonight. And the friend, thinking they're doing a good deed, gives the individual a prescription opioid, and then it begins. So many of these individuals are getting them right from our own shelves. So it's really important to know what's on the prescription shelves, use the disposals, which are in every town, every police department, a lot of pharmacies around our country, and get rid of old medications that are no longer used by your family, because that's where the majority of our prescription misuse and abuse is coming from. Very, very few are buying their substances from a drug dealer or a stranger or someone on the street. And like I said, many of them are not getting it through stealing prescriptions from providers, but rather going to just one provider and one pharmacy. So it's a really important slide to look at. We know that co-occurrence occurs. I don't think we have a full handle on what how significant co-occurrence of mental health disorders and substance use disorders is in our country. It's always been estimated, at least in my career, that about 50% of individuals with a substance use disorder have a co-occurring psychiatric diagnosable disorder. Although, substance use disorders fall under the DSM-5, so I don't know why we differentiate, but we do, and we call them co-occurring. Amongst our youth and young adult population, 5.1 million individuals aged 18 to 25 had a substance use disorder in the past year. And of those individuals, about 47% also had a co-occurring psychiatric diagnosis. Among our adult population over the age of 18, at 19.7 million suffer from substance use in any given year, and about 46% of those have a co-occurring psychiatric symptomatology. Yet, so few of our individuals with both psychiatric as well as substance use disorders get any kind of treatment, whether it's for the mental illness itself, whether it's for the substance use disorder itself, and far and away for the comorbid disorders, treatment is really lacking in our country. About 92% didn't receive any kind of treatment, which is really, really a very sad testament, because in my world as a nurse, all health begins with mental health, not just because I'm a psychiatric practitioner, but because mental health guides our physical health. It's kind of like putting that oxygen mask on yourself first. We need our mental health and our faculties, our cognition, to have our stress at a relatively reasonable, manageable level, to be able to move forward in the rest of our lives and manage our full body health. So it's really sad that we spend so little in treating not only comorbidities, but also the single diseases as well. What kind of cost is there to not treating co-occurring substance use and psychiatric disorders? Well, in 2014, we had over, almost 44 million individuals with psychiatric disorders. We added another almost 22 million over the age of 12 with a substance use disorder, and about 8 million which is still consistent today in terms of these statistics and numbers, with co-occurring disorders. We have about 43,000 adults dying by suicide. Now, again, since COVID, that number's risen about 30% in the last year. And that cost us back in 2016, just 5 years ago, over $44 billion in lost work, productivity, and medical costs to treat individuals who may end up committing suicide. About 33,000 Americans die by opioid overdose. Again, this number is greater. And back in 2013, when they gave us a cost estimate, it cost almost $80 billion. And then 64,000 other Americans die from other substance use overdoses. So if we look at that collectively, we add up those who committed suicide, those who've died via opioid overdose, those who've died from substance use overdose. We have a collective group of individuals that would rival cancer. It would be in our top 3 disorders. Co-occurring substance use and psychiatric disorders is in the top 3 for death in our country, if we look at it together. When we look at it separately, it ends up being 10, it ends up being 15 on the scale. So maybe it doesn't get as much focus if it's the 10th leading cause of death. But if we look at it together, I think we've got a pretty strong case for why we need to focus more on this population in particular. So that's kind of the epidemiological section. Let's now get into the brain and genetics. We have a wonderful adaptive machine in our body called the brain. There are many factors that go into substance use disorder and the addicted brain, as I call it. We have the biological and genetic factors, and we're going to go through some genetics in a moment. I'm going to give you the mini bio lesson here. We have environmental factors. I think all of us can identify what those environmental influences may be. Parents who may have a substance use disorder, friends and peer influence, community attitudes towards substance use disorder. Lack of participation in activities is a big one for children and youth who enter into substance use and misuse. At poor school achievement, chaotic homes, trauma. We're going to talk a little bit about trauma in a moment and how that actually affects the brain's neuroplasticity. And then we have our biological. Of course, genetics. If you have a first-degree relative who has a substance use disorder or psychiatric disorder for that matter, you are more likely to be at risk for substance use and or psychiatric disorders. Men are more predisposed at risk than women are. Men having a comorbid psychiatric disorder places you at higher risk. Then the drug itself determines whether or not the individual may be led into more of a use disorder or addictive state. The drug itself, if you're using it earlier, if it's available, if it has a low cost, you might be more likely to use it. If it's easier to administer, you might be more likely to use it. And then the effect that the individual obtains from the substance itself. Then we bring in the brain mechanisms, and we're going to talk more extensively about that. And that all brings us to substance use disorders and addiction. So I'm going to try not to bore you, and I'm going to try to make this understandable, but we have some factors that we can look at from a genetic standpoint that can influence and tell us not only if the person is at more risk for a substance use disorder or what type of substance use disorder they may be at risk for, but also what kind of treatments may be available to that individual with certain genetic variants. Variants are the type of gene that you get from each parent. You get one gene from each parent. So let's take the domain of treatment response. Here we're looking at genes that may tell us if an individual with a certain variant, a certain genetic profile coming from each parent, in this case, the gene is the opioid mu receptor gene, and the variants are 2A. So each parent gives an A gene, an A allele, we call them, to the individual. That individual is going to have a better response to naltrexone. If they're presenting to you with an opioid use disorder, the person with this particular genetic variant is more likely to respond to naltrexone. So right there, we have kind of a step up that could give our patients a chance if we do look at genetic testing. Similarly, the GRIC gene and CC variants from each parent would be, that individual may be more likely to respond to topiramate, which is Topamax, an old anti-seizure medication that we sometimes see used in mental health these days. But topiramate can be very helpful in treating our patients with alcohol use disorder and helping them reduce those cravings and heavy usage days. Now, if the patient had an AC variant on either of those, they wouldn't be as likely to respond so well to either of those treatments for respective opioid or alcohol use disorders. What are our patients getting out of these things? Well, in terms of that opioid receptors, again, if they have the AA variant, they're going to have a nice response, a pleasurable response to the opioids. They're going to feel that high, if you will. But if we use naltrexone to treat them, that should help with their use disorder and their recovery. If they have a dopamine gene, the D2 receptor, and they have a C and deletion, they may not respond well to antipsychotic medications. So we may not do our patients a disservice, or we may do our patients a disservice by prescribing antipsychotics for a patient with this particular variant because they're not going to be likely to respond. If we have the patient with the CHARNA A5 gene, which it relates to nicotine, and they have the AA variants, again, they're going to be much more risk for nicotine dependence. That's often an overlooked substance use disorder, as is caffeine in our country. Many individuals would meet the substance use disorder criteria for nicotine use disorder as well as caffeine use disorder. What about stress? Well, the NPY gene and this particular TC variant tells us our patients are going to be more likely to be susceptible to anxiety and depressive states. The COMT gene, which is it looks at dopamine. Dopamine is one of our pleasure-enhancing neurochemicals, which is often released when patients take a substance of abuse like an opioid or alcohol or cocaine. If they have the VAL met, they may have a better response to the stimulant medications, but they also may be more susceptible to substance use disorder because their dopamine levels in that prefrontal cortex that helps us think through and reason and make better decisions is not as full and robust as it might be in another patient. Patients with the serotonin transporter, which is the SLC6A4 gene variants of LL, may be better responsive to the SSRI antidepressants like Prozac, Zoloft, Lexapro, but may not do as well on other types of antidepressants. And then similarly, if our patient with COMT has that VAL met, they're going to be more likely to have hyperactive, impulsive, risk-taking behaviors and potentially lead them to a substance use disorder. So using the psychostimulants may be a helpful treatment for that individual. And it may actually, you may say, well, how could a stimulant, which is a controlled substance, be helpful for somebody with a substance use disorder? Well, sometimes you have to treat what's contributing with a substance, just like we treat opioid use disorder with opioid agonists, which is an opioid enhancing medication like methadone or buprenorphine. Similarly, the MAOA gene, those patients might have more susceptibility to aggressive states. So that's your mini genetic lesson. I'm not going to belabor that, but aggression, impulsivity, risk-taking, we can identify some of these things for our patients and predict where they may lie in terms of risk factors as well as treatments. So we don't use genetics a whole lot in our society yet, but they've been around. As you can see, these genes have been identified and studied extensively over the past 15 to 20 years. So it's not new, but in mental health, substance use disorder treatment, we kind of are always the redheaded stepchild and behind other forms of medicine and treatments. So looking at the brain, and going forward, we know that the brain takes its time to mature from early childhood. So the brain on the left-hand side of your screen that you're looking at is a 5-year-old brain. All of those colors are undeveloped portions of the brain, in particular, the prefrontal cortex, which is the area that's in front. I'm using my pen as if I have a laser pointer for you here, but the prefrontal cortex is that little area in blue in front of the green area. That is our executive decision-making portion of our brain. That is the portion of the brain that takes the longest to mature and reach its fullest capabilities. For males, that can be well into the 20s, or well into the 30s, actually. And really, we don't even think of the brain development as being even remotely fully developed until the 20s. Like I said, there's been Nora Volkow at the National Institute of Mental Health has done a lot on substance use disorders and brain development and influence, and has some information that shows male brain development doesn't even mature until about age 35. So no offense to our male, our male colleagues out there, but there is science behind this. And what we see here is the gray matter development in the prefrontal cortex, in the parietal lobes of the brain. We'll look at that in a little bit. The temporal lobe starts to mature. We start to see that dissipation of red and yellow about age 16. And then the occipital lobe increases as well into the 20s. So we're seeing this myelinization of the brain, and we're going to talk about how trauma affects that whole structure of our neurons in a moment. So what we do have with our brain is a lot of what we call synaptic plasticity. We used to think that our brain kind of stopped developing. We didn't regenerate our brain cells after the age of 50. And fortunately, our brains still develop after the age of 50. We know that now. And that's called neuroplasticity. The more plasticity we have, the more learning. So we can teach us old dogs like myself new tricks, new learning experiences. Those synapses get strengthened by each new learning opportunity we present to it. So when we think about this in the context of our patients with substance use disorder, it's not hopeless. It would be, it would be a real detriment if we gave up hope on our patients, even though they've had a long chronic history of substance use disorder, because they can continue to learn. They can continue to strengthen their brain and recover it. And at the end, I'll show you a recovered brain, which is kind of a neat slide. In early childhood, we have millions of neuron connections that occur on every single second. By the teen years, we kind of prune those out. We kind of get rid of the ones that really aren't necessary to help us learn how to walk, to talk, all those early developmental stages that we go through. And then in adulthood, we become more specialized. We may have a specialized career track. We may have a specialized learning track. We may have other creative specialties, and we have this much more mature brain that can continue to develop throughout our lifetime. What does stress do to this neuroadaptive predictability in our brain? Well, persistent stress changes that brain's architecture. So we've heard a lot about toxic stress, the ACE scores, the adverse childhood event scales, looking at toxic stress on the brain. Toxic stress can come from any number of sources. It can come from exposure to drugs. It can come from trauma and abuse. It can come from exposure to traumas, such as we're coming up on the 20th anniversary of 9/11. If the child, if the individual was a child back in that period of time, that was a toxic and traumatic event. Our children today are having a traumatic, toxic event, toxic, stressful event, given the COVID pandemic that we are under. And when that happens, when our brain, as it's growing, is exposed to these stressors, those connections become damaged or they become fewer. And you can see with the top neuronal connection, you can see all those little spiny, if you think about it like springtime with the buds on the trees, we've got a lot of buds going on there that are going to bloom and flourish. And then you have a big storm that comes through and presents a stressor to that tree, and it breaks off a number of those buds that are that may have the ability to bloom and flourish. So that happens in our brain. And if that is occurring simultaneous with an individual being presented the opportunity to use some sort of substance, that is going to be the connection that gets strengthened, and the individual may be more predisposed to use substances at that point. We also know that there's regions of our brain that have reward and that reinforce reward, or that weaken those reinforcements, and that have stress and negative reinforcements that are strengthened. What we see here is that the prefrontal brain underperforms, that we're not using that executive brain to its fullest capabilities in these situations. And that alters a number of the neurochemicals to send those messages that, hey, this isn't such a great idea. We've got an immature brain. We've now exposed it to stress and reduced some of those connections that we're strengthening, giving resilience to that individual. And now we're taking those things away, and we've stripped them down, and we've exposed them to a substance of a potential abuse. And we have this perfect storm where that reward from the substance that's going to feel good, that's going to help them, be numb, maybe forget that stress or what have you. And that may lead to that high feeling that people describe under the influence of substances of abuse. Then the the withdrawal period may hit, causing that negative reinforcement. I don't want to feel like this. Withdrawal is terrible. And that reinforces the need to go back to that substance of abuse. So let's look at a couple of different substances of abuse and what happens in the brain and how different regulatory systems take over. These are images of the brain looking at dopamine receptivity. Most of our substances of abuse will have some influence on dopamine. Dopamines are pleasure-enhancing neurochemical. It's our motivating neurochemical. It gives us our libido for intimacy. It gives us our ability to think cognitively. When there's too much dopamine, we may have movement disorders. If we don't have enough dopamine, we may have psychosis. And so dopamine plays a very, very strong role in our brain, and also a very, very strong role in substance use disorders. So when we administer drugs just short term, say for pain management post-surgical procedure, there's going to be that reward, that relief of the pain. However, if we continue to expose the brain to that substance, that reward's going to decrease over time. Tolerance is going to build up. Seeking higher levels of the drug, seeking more of the drug, more frequent use of the drug to get that reward back. And what you can see here in these brain images is the effect of various substances on the dopaminergic input of the brain over time. So with what you're seeing is the red area of the brain. There is the dopamine. We have a lot of dopamine receptivity and availability, which gets diminished over time. That red disappears. Chronic cocaine exposure markedly reduces that. Methamphetamine, you can see the deterioration of the brain. You can see a number of different areas of the gray matter, the dopamine, the other neurochemistry and actual structure of the brain begins to deteriorate. You can see the holes literally in the brain. Alcohol, the individual starts out with a nice robust dopaminergic state, and that gets reduced. And we see cognition and other areas of the brain become eroded. Heroin and the opioids similarly. So when we used to see our brain on drugs, when we had those commercials back in the 80s with the egg in the frying pan, or, you know, if you're old like me, the egg in the frying pan or the egg on the hood of the car, and that was your brain on drugs. Well, now we can actually see really what happens with our brain on drugs. And I use these slides to show my patients, you know, this is what happens. And we do have a more hopeful slide at the end to show how the brain with its neuroplasticity can regenerate, and we can reverse this course of action and regenerate those brain cells. So what kind of neural pathways? I know, again, we're looking at the brain here and all of the neuroanatomy and physiology and neurochemistry that goes on. So if we're looking at our brain, it's built from the bottom up. So if we go from this long, you know, kind of bone-like looking structure, which is the brainstem, and work our way up to the top of the brain, our prefrontal cortex. So we're going from basically the base of the neck and the spinal cord and the brainstem up through the prefrontal cortex. We have our very primitive functions occurring in the brainstem. Those are our reflexes, our need for food, our need for sleep, our heart rate is regulated there. It's kind of our regulatory center. Then we move into kind of the middle brain. That's our emotional brain, often referred to as the limbic system. And the amygdala, which kind of sits right in the lower center of the brain, it's that little kind of gray pebble-ish looking thing that has all the red arrows extending, you know, around it. The amygdala is our fight or flight center. That's the center of stress for our body and how we're going to manage stress. And when that amygdala gets activated, we can activate it in a way that's helpful to us or harmful to us. And we'll talk a little bit more about that in a few moments. Our hippocampus sits right near to the amygdala. That's our storage center. If anyone's watched Inside Out, it's an old Pixar film by Disney. It does a great job of looking at how these things happen in the brain in a very easy to understand, even childlike, if you will, way. The hippocampus stores those memories. It stores the memories of trauma. It stores the memories that an individual's gone through withdrawal because they didn't have enough of the substance to keep, them feeling relatively stable. And all of those memories then dictate how an individual may respond in the next situation when they are presented with a substance of abuse. That prefrontal cortex that I talked about, that executive brain, and sorry, I realize I'm using my hands a lot. I do that when I'm up talking in person, and it's a little bit odd because I'm using my hands in terms of reaching out to you all. But that prefrontal cortex then gives us our reasoning, our planning. Are we going to plan for the next use of the substance to avoid the withdrawal? Or are we going to work on harm reduction and have those brain cells in that area of our brain take over and help us to make decisions for harm reduction and health? The neuropathways, again, looking at a different slice of the brain here, we have many drugs that activate that reward system by increasing that dopamine. In fact, it's shown that our prescription opioids and heroin provide a burst of dopamine 25 to 100 times greater than that of our own endogenous opioids. When we think of endogenous opioids, we're talking about the opioids that naturally occur in our body. When we talk about a runner's high, if anyone's been a marathon runner, or if, for me, accomplishing 20 feet might be helpful, but you might get that burst that can keep you going, that kind of takes over and helps you to feel good. It helps you to have that motivation to get through that last, 10 miles or what have you, or that last 2 miles. Heroin, the opioids, give that huge, robust release of dopamine. So it feels really good for most people, unless you have a genetic predisposition that really says you don't respond well to the opioids. So that occurs in the nucleus accumbens. And when we talk about the nucleus accumbens in the ventral tegmental area, it starts in the ventral tegmental area. Then you get this robust burst in the nucleus accumbens. And then the projections there regarding neural pathways determine how the individual will handle it from that point forward. So we have the reinforcing effects of the drug, like I talked about, that robust dopamine release. Then we have the negative enforcers of withdrawal that go into the amygdala, and the amygdala goes on activated alert saying, oh, fight or flight here. We've got to either, use again or suffer the consequences of withdrawal. Then we have that preoccupation, that prefrontal cortex comes into play and says, you know what, should I still keep using? I really want this. I really want to avoid that feeling of withdrawal. And I really like that high effect. And so the preoccupation becomes, constant in that prefrontal cortex. So depending on how those positive and negative reinforcers coincide and how much the brain's neuroplasticity is developed will determine whether or not individuals may be led into a substance use disorder. This same process occurs and presents itself for opioids, for nicotine, for sex, for food. It's very, very similar process. All of these things release that dopamine in varying levels. Sex, food, if you look at superimposed graphs, the opioid level or the dopamine levels are very, very similar when you introduce any of these things. So no wonder we have, many addictions or use disorders in our society related to these things. They feel good. That prefrontal cortex, again, our decision-making. And there are things that contribute to good decision-making and not so great decision-making. Healthy, I like to couch it in terms of health. A lot of my patients come in and they say, I was bad this week. That's one of my least favorite words in treatment. Sorry, I had a little ice cube there. One of my least favorite words in treatment is good and bad, because it's not good or bad. It's healthy or non-healthy. Are you making healthy decisions this week? If you've smoked 5 less cigarettes, that was a healthy decision for you. If you've used 4 bags of heroin instead of 10, or instead of 5 for that matter, it's a healthier decision. So we want to strengthen those connections here and help our patients to make those healthier decisions. Individuals with ADHD, our kids with ADHD, when we don't treat that ADHD, which is really a function of the executive part of the brain, that prefrontal cortex, that is going to lead to potentially more problems down the road, because that child realizes there's something wrong. They aren't able to control those impulses. They aren't able to focus, pay attention, organize themselves in a way that makes sense and that's productive to help them move through school, social events, family events, etc. And for adults, it goes the same way. So that individual, there's often been a correlation of ADHD and substance use disorder, and untreated ADHD leading to substance use disorder. It does have that propensity. So that's something to also keep in mind for our youth population. Let's take a look quickly at some of the neurochemicals that are involved. And these are our 2 neurons. We have sending neurons, which is the peach color, and we have the receiving neuron, which is the bluish gray color. And when we introduce a substance, it has to get from one place to the other to have its effect. We have billions of these neurons in our brain. And so every one of those circuits has to work in concert with one another. When we have drugs that block these areas, you may get a more robust effect of the substance in what we call the synaptic cleft, that little gap between the sending neuron and the receiving neuron. And that is where the effect of the drug becomes either problematic or not problematic. If it's being used in an acute situation for short periods of time in minimal doses, more than likely individuals can tolerate that. If it's higher doses, longer periods of time, more frequent dosing of it, that leads to more substance use disorder potential. So there's activation on the presynaptic side with cocaine, the amphetamines, the stimulant medications. Also, our drugs like morphine, the opioids, nicotine, marijuana kind of cross both the presynaptic and receiving neurons. And then drugs that are involved in more of the receiving neurons are our alcohol, our ketamines, our hallucinogens, and the likes. When we talk about the chemicals that affect our brain, most of us have working knowledge, at least, of what we call the trimonoamines: serotonin, dopamine, and norepinephrine. They are the triumvirate of mood, thought, and behavior in our psychiatric world, if you will. They also influence substances of abuse. When their functioning is quote unquote normal, whatever that is, or what we consider societally acceptable, serotonin will help to stabilize emotions. It will help us be able to reach a dream state that is helpful and productive and restorative. It will help us manage pain and pleasure, aggressive tendencies. Drugs of abuse that act on serotonin, which can be negative or positive, include substances such as alcohol, nicotine, the amphetamines, the hallucinogens, the benzodiazepines. Dopamine involves our muscle, our energy, our motivation, our reward, our pleasure. We've talked about that. Cocaine gives that robust release. Nicotine, PCP. PCP actually can be one of the most difficult substances of abuse when a patient is under the influence of PCP. There aren't agents that really counteract it, and the aggressive tendencies, that dopamine overtake for the individual, just creates this kind of superhuman strength, which is very, very difficult to manage in a medical setting and in a community setting for sure. But the amphetamines, we expect those to have that pleasurable dopamine release. And surprisingly, alcohol and opiates, even though they are thought of as more depressive states, they do give that pleasure and reward. Norepinephrine helps with both energy and motivation, but also our thought processes, our ability to reason, our ability to think through things, plan, organize, keeping us alert. It also manages our basic some of our basic bodily functions, our sympathetic nervous system. So when individuals are anxious, their heart rate, their blood pressure may go up. Similarly, when an individual goes into withdrawal from some substances, their heart rate, their blood pressure may increase over time. Drugs that influence norepinephrine include cocaine, marijuana, nicotine, MDMA. And then some of our lesser known neurotransmitters, but you may recognize the impact on some of the prescription psychotropic medications, glutamate and GABA. They are glutamates are excitatory neurochemical, GABAs are inhibitory neurochemical, are calming neurochemical. GABA is influenced by alcohol. It's influenced by the benzodiazepines. It's relaxing, it's calming in its normal and regular usage. Glutamate's more excitatory, caffeine, alcohol in excess will trip that glutamate switch, and as will the tranquilizers such as the benzodiazepines. Acetylcholine, we think of that more in terms of our dementia medications used for dementia, the anticholinesterase inhibitors. So it's involved with the cognition for our patients, but it's also involved in sympathetic nervous system. And many of these same drugs overlap and impact acetylcholine, which is why you may see cognitive decline with long-term use of agents like marijuana, alcohol, nicotine. You see that cognitive decline over time. And then our endorphins. We have our naturally occurring endorphins to help us manage pain, to help us with our stress management. And heroin, opioids, alcohol, basically the whole cadre of substances of abuse also help enhance those endorphins. So what are the effects of opioids on the brain? We'll kind of flip back to opioids and pick on that substance of abuse for a few minutes here. So opioids interrupt all of the circuits in our brain. We have, the drug causes stress. It causes an induction that creates a neurobiological dependence that leads to this craving, that leads to this anxiety, which then activates the amygdala to figure out, what should I do here? Fight, flight, the anxiety's up, the urgency's up, those cravings are up. And the ability to reason, the ability to move forward with the prefrontal cortex taking over as our executive brain is reduced. The prefrontal cortex, again, should be responsible for our goal setting, for our planning, for our organization, for controlling those inhibitions and cravings. But when we introduce a substance like the opioids, or many of our other substances for that matter, we disrupt this whole entire circuit and therefore lead to the perfect storm of a substance use disorder. Here's another great scan of our brain and our brain on drugs. So this is a healthy brain on the left-hand side, and we have an unhealthy opioid-induced brain of 7 years on the right-hand side. And you can see the gray matter, the white matter that has deteriorated and eroded substantially with the exposure to the opioids over that period of time. So again, pretty powerful slide that I often show my patients. And this comes from Daniel Amons. He uses a lot of the SPECT scans to guide his treatments. He's got a couple clinics around the United States. And his slides are his scan slides are really fascinating and powerful imagery for our patients. So what do we do about treatment? Well, our old model of treatment for substance use disorders was that it was really an acute treatment, that a patient would enter treatment, they'd get assessed, they'd get treated, and they'd get discharged, whether that's through a detox or through maybe a 90-day program. And then that was kind of it. Now we're looking at the disease of the brain of substance use disorder in the chronic care medical model, which is looking more at prevention, looking at harm reduction, and intervening early for educational purposes and treatment purposes, and then supportive long-term recovery. We wouldn't expect someone with diabetes to be seen once, twice over the course of a couple of months and then discharged from care. That diabetes is more likely to be a lifelong condition, as is substance use disorder for our patients. So looking at it from a harm reduction, looking at it as a chronic relapsing disorder that it is. We don't kick our patients out of our practice if they eat a piece of cake when, at a wedding and they're diabetic, nor should we kick our patients out of our practice if they have relapsed or used their substance of choice. In fact, that's a very punitive thought, and we're really trying to change that in the substance use disorder field these days and support that recovery. It's more proactive as opposed to a passive treatment model that we're looking towards. Hopefully all of you are aware of SBIRT, which is screening, brief intervention, and referral to treatment. The referral to treatment becomes very challenging for the very reasons I spoke of back in the early slides. We don't have enough providers, and less than 10% of our patients get treatment for comorbidities of psychiatric and substance use disorders, and not a great number larger get treated for either of those conditions independent of one another. But because we're working on a chronic care model now, the screening is really a critical piece. And it's a really brief 1 to 3 question screen. Have you used substances of abuse? If so, what? If so, how often? If that's positive, you're going to explore more. You're going to explore further. One of the more helpful things that I just contradicted myself with is to ask open-ended questions. How often do you use alcohol, for instance, as opposed to do you use alcohol? That's going to require a different type of response than yes or no, and it keeps the conversation going. So the screening tools now are looking at how often are you using. So there's kind of the assumption, and that's not to be rude to our patient, but it's just, a simple question. And then when we intervention doesn't necessarily mean, oh my goodness, we have to get this person into treatment today within the next 2 hours, or they're going to be at high risk. Intervention really is just that. It can be education, it can be advisement, it can be encouraging, it can be a teaching moment. And each time you have the opportunity to do that is another step towards that patient's potential health and overall well-being in light of their substance use disorder. Referring to treatment, of course, keeping a record of places in your local community that you've got a relationship with, that you might be able to support a patient who makes that decision and is ready to enter into care would be really helpful. The American Psychiatric Nurses Association has a pocket screening card for substance use disorder. It works on the 3 National Institute of Drug Abuse quick screens, and it's a downloadable freebie tool. So if you go to APNA's website and look for that, it's a great little screening tool that can be used in any setting whatsoever. And you can also put some, personalized information about referral sources and things like that may help you. And there's a couple little tips on intervention, how you can educate and teach and inform your patients during that interaction. What about care? Well, our care in our country has to be manageable. It has to be personalized. If you have an individual who's coming in and they say, you know what, I'm ready. I think I want to enter into a methadone treatment clinic. I have an opioid use disorder. I think methadone's the structured program for me, but I don't have transportation, and the nearest methadone clinic is 20 miles away, and the bus only runs 3 times a week. Is that going to be a feasible option for that patient? More than likely, no. Similarly, if a patient is in treatment and gets discharged, that has to be reasonable. If they have young children at home that need childcare, is it going to be reasonable to have that individual go to a facility for an extended period of time? So all of those factors need to be taken into consideration as the whole person. in order for our treatment plans to be effective for our patients these days. So we need to look at the individual. We need to look at what's the basis for this particular intervention. We have to look at past history for our patients and what has worked or not worked. We have to look at other factors. Are the stressors that the individual is under, are there comorbid needs like psychiatric considerations, medical considerations for a patient? So all of these things must be taken into consideration when we're looking at treatment options for our patients. Likewise, for those of you who are prescribing clinicians and for those of you who aren't, it's perfectly reasonable to talk with the individual prescribing clinician and talk about the laboratory workup, looking at the toxicology screen. If an individual's entering into methadone, looking at an ECG, it's electrocardiogram. We used to have it electrocardiogram with the K, the German spelling, way back when. Looking at blood count, this may be the first time our patient has had a laboratory workup in years, if not decades. I just had a woman that I saw before I started recording for you all today that she hasn't been to her primary care practitioner in 12 years. She's highly successful. She's been on a course of buprenorphine to maintain her opioid recovery for a decade, but she hasn't taken care of her own physical health. So these are opportunities that we can look at not only the substance use disorder, but our patient's physical health and needs as well. Here is a slide that you may want me to send you in larger format down the road. This is how long substances remain in the body. There's a reason we often do urine drug screens as opposed to serum blood screens. Substances stick around in the urine longer than they do in the blood. As you can see, it's more hours that a substance may be visible on a drug screen, whereas on a urine drug screen, it's days and sometimes even weeks. So alcohol, 3 to 5 days in a urine, you're going to show positive for alcohol if there's been enough in the system. Whereas alcohol on a serum, a blood draw, is only going to show up for about 12 hours. Marijuana only lasts on a blood draw about 24 hours versus urine, which can be up to 3 months, give or take. Similarly, down the line, let's see, what are some of the highlights here? Are opioids 3 to 4 days in the urine. Depending on the type of opioid, some have longer half-lives, therefore they will last longer in the body. So that may be extended a little bit if the person is using a longer half-life agent such as methadone, whereas it may only show up for 12 to 24 hours on a blood draw. Our stimulant medications, Ritalin, for instance, or Adderall, methylphenidate, or the mixed amphetamines really aren't going to show on blood screens, but they may show up for a day or two as a stimulant in a urine screen. Benzodiazepines, 7 days to 6 weeks if a person is using a benzodiazepine, where it may only show up for 48 hours or so on a blood draw. What about false positives? I always get asked this question because, with patients having worked in various medically supervised withdrawal facilities and the likes, patients are, well, you know what? It shouldn't be positive for methadone. I don't know why. Maybe it was the poppy bagel I ate. Well, there's definitely truth to that. Poppy seeds do mimic they replicate the opioid identically. So if there has been enough poppy seed ingested, it will show a positive for opioids. And you're going to be hard pressed. It's not going to be something that you'll be able to differentiate even on a more a screen that is more thorough than an in-office on-demand urine drug screen. Things like Benadryl, diphenhydramine may cause a false positive for methadone. Psychiatric drugs like quetiapine, Seroquel, trazodone, sorry, I have a couple of spelling errors here. Quetiapine may show positive for methadone, whereas trazodone, frequently used off-label sleep aid, may show positive for benzodiazepines. Drugs like our NSAIDs, ibuprofen, Advil, Motrin, may show positive for marijuana or the barbiturates. Antihistamine drugs may show positive for dextromethorphan, such as dextromethorphan may show up as PCP, whereas the amphetamines and methamphetamines may show up as other antihistamines like Sudafed and ephedrine-based. Bupropion, Wellbutrin, common antidepressant, may also show up as an amphetamine. So being aware of these things is very important as well. Oops. Oh no, sorry. It's not letting me advance here. When we look at opioid withdrawal, and I think the next slide is also alcohol withdrawal, we're kind of getting to the end here. Early withdrawal, you're going to see what I call the runs. You're going to see teariness, you're going to see runny nose, you're going to see sweating, you're going to see the runs. And then it moves into the next phase where the abdominal pain begins to develop. And then full-blown withdrawal occurs about 1 to 3 days. If it's a person who's using a longer half-life agent like methadone, it may actually take a little bit longer to develop that full-blown withdrawal, where that sympathetic nervous system kicks in. The blood pressure goes up, the breathing increases, the heart rate increases, the nauseousness, the restlessness all occur. And then the stage 4 is where the person is doubled over in that fetal position with the diarrhea, the vomiting, usually saying that they just want to die, or let me out of this place so I can go back and use because I can't tolerate these feelings. Similarly, the alcohol benzodiazepine withdrawal has a similar progression. The risk with alcohol and benzo withdrawal, however, is seizures. I have seen patients walking and talking with a blood alcohol level of 480, and the next moment they are in grand mal seizures, being intubated and taken to the ICU. It occurs rather abruptly within 6 to 24 hours of last use. And if the person is using a higher proof alcohol, say, 151 rum versus a 4% beer, you're going to have that process occur much more rapidly, like I just described. But your symptoms, 6 hours or less, the person might have some mood lability, maybe a little bit of impaired judgment, maybe a little slurring of speech. Within that first 24 hours, really critical, looking at the heart rate, looking at the sympathetic nervous system once again, the sensitivities. 24 to 72 hours, the DTs, the delirium tremens, the hallucinations, the experience of things crawling on them increases, as well as temperature. And these are medical emergencies when it occurs with alcohol and benzodiazepines. When we look at medication-assisted withdrawal, we're looking to decrease that arousal, decrease that sympathetic nervous system from a health perspective, lowering that heart rate, lowering the blood pressure, using medications like blood pressure, antihypertensives to do that, reducing the auditory, visual, tactile disturbances with antipsychotics such as haloperidol. There's other medications that we can use to treat substance use disorders. There aren't a whole there's definitely not a plethora of FDA-approved pharmacologic agents for various substance use disorders. As you see, the sedative hypnotics, the stimulants being abused have no FDA-approved pharmacotherapy. We use a lot of these agents off-label. Off-label for alcohol, we use the antihypertensives, we use the anti-seizure medications. We do have disulfiram, which is antabuse, which induces vomiting if a person drinks while on it. We also have naltrexone, old drug, more commonly known as Vivitrol in the intramuscular injectable form for opioid treatment, but it was originally developed for treatment of alcohol use disorder. And we can use that on a monthly basis as an injectable. The opioids, we have buprenorphine, we have methadone, and we have naltrexone as approved, and then a various grouping of medications to ease those withdrawal symptoms. For nicotine, we have bupropion, Wellbutrin, repackaged, known as Zyban. We have varenicline, which is Chantix. And then we have all over-the-counter as well as prescription strength nicotine replacement agents. But there aren't any off-label pharmacotherapies that we use for nicotine. So you can see the field for treatment is not nearly as wide as the field for potential abuse of these substances, which again causes some problems for us as well. What about opioids in particular? Well, the three medications that the FDA has approved for use for opioid treatment all work in their respective manners. I'm going to flip to the next slide here because it's a little more comprehensive. We have methadone, which is a pure, well, it's a pure synthetic, total replacement, opioid replacement. So you are replacing an opioid with an opioid, but the fact of the matter with medication assisted treatments here is that they do reduce the cravings, they do reduce the physical health issues that go along with substance use disorders. They also have been known to reduce hospitalizations, reduce criminal activity, and jail time and the likes that we often associate with, or that we have associated with substance use disorders in the past. Buprenorphine, commonly known as Suboxone, when it's combined with naloxone, is another opioid replacement. It's a partial replacement for the opioid. Again, very helpful. Opioid replacement using buprenorphine can occur in an outpatient office with take-home doses, unlike methadone, where you might have to go in on a daily basis. However, during COVID, some of those federal restrictions on how often take-home can occur and under what circumstances have eased up a little bit. So there's been a bit of a freeing, which hopefully will carry forward once the pandemic is deemed under control, and we'll still be able to manage opioid treatment in a more respectable manner for our patients. Many of our patients find it very difficult to get to a methadone clinic on a daily basis, whereas Suboxone may not, or buprenorphine may not work as well for them. The third FDA-approved agent is an opioid antagonist that completely blocks the opioid receptor, and that's naltrexone. Excuse me. And with naltrexone, if the individual uses an opioid, it may put them into a precipitated withdrawal. So in some ways, I don't want to necessarily compare it to antabuse, as antabuse is to alcohol. The naltrexone can be somewhat similar related to the opioids, but it has been a very, very helpful agent for many patients to maintain their health and move through their recovery and harm reduction related to their substance use disorder. It's an injectable on a monthly basis. The drawback here is the patient must be 7 to 10 days without opioids. That includes tramadol, that includes any kind of opioid, Suboxone, buprenorphine, methadone, to begin usage, because otherwise that precipitated withdrawal will occur, and you're basically sending your patient immediately into stage 4 with withdrawal from that chart I showed you a few minutes ago. So depending on your patient, depending on their motivation, depending on their access to care and the likes, deciding which agent will work for them. All three have shown equal efficacy in treatment, and that's the important thing. I'd be remiss if I didn't show a slide on naloxone, Narcan treatment for opioid overdose. Narcan, naloxone will buy you a brief period of time to get the individual into an emergency to an emergency department for further treatment. It is just a quick reversal. It is not an extended recovery. It will help the individual stay alive basically 45 minutes or so to get to an emergency department for further recovery. So identifying the overdose, if you happen to make a misjudgment and the person isn't in an overdose situation, you're not going to harm them by giving them naloxone. In fact, you may save their life if you do rescue breathing, if that's necessary. But staying with the individual, I know there's been a ton of word on the street that it's not really effective. People go to the emergency department and they leave, and 911's called again and they've overdosed again. With fentanyl on our streets these days, this has become very problematic. The single dose may not be enough naloxone to reverse the effect of the opioid overdose, so they may need repeated dose administrations. So that's an important piece to keep in mind as well. Making sure that all your patients, regardless of substance use type, have a prescription for Narcan, or can go into any pharmacy around the country and ask for a prescription for Narcan. It's available in that regard. Fentanyl is being found. Fentanyl is a highly, highly potent opioid, and it's being found in marijuana, it's being found in cocaine, it's being found in many of our other substances of abuse these days. So it's a dangerous world out there for our patients to navigate with substance use disorder. So just a real important piece to make sure your patients have Narcan. And then looking at relapse factors, of course, the phone calls from friends, withdrawing again, having chaotic or problematic relationships, having too much time on your hands, withdrawing from meetings are all symptoms of our relapse and symptoms of unhealthy, risky behaviors that may cause the individual to have a relapse situation. And I told you I'd show you about the neuroadaptation of our brain with abstinence. And again, we're looking at a harm reduction model today. So, the language of the day a decade ago was abstinence and addiction and abstinence. Today, we're looking at substance use, harm reduction, recovery. And with an individual who has reduced their harm or remained without substance over a period of time, we are restoring that brain to a relatively healthy level. You can see the deterioration, still the holes related to gray matter, but that dopaminergic activity is healthy, which will help our patients be able to make better decisions. That prefrontal cortex cognition is coming back in a healthier way for our patients, and the rest of the brain will then follow. Our brain is the neuroplasticity will regenerate those brain cells and flesh that brain out to be healthy once again. So just to take away, our brain is able to learn. We can teach old dogs new tricks. We can teach individuals and help the learning process to occur and reverse the effects of substance use disorder. The brain development goes into the 20s and even 30s these days. The amygdala, our fight or flight center, and prefrontal cortex are really important regions for substance use disorder, with that reward and that negative reinforcement of the withdrawal symptomatology. Dopamine's our big neurochemical that modulates the disease of substance use disorder, but we are neuroplastic, we are neuroadaptive. Medication-assisted therapies are out there to help that addicted brain in its recovery, and not just abstinence, but full health, full body health. So I appreciate your time during this virtual presentation, and I hope that you have an enjoyable rest of the conference. Feel free to be in touch with me if you need something in the future. And again, here are a couple of resources of vetted sites that provide some very, very excellent substance use disorder information for you. And if we were live, I would love to respond to questions and answers. That's one of my favorite things, so I will miss that, but enjoy your conference. Thank you.